Okay, and our next speaker is Dr. Don Fletcher. He's one of Smith-Kettlewell's clinical scientists. And as we set up here,
Functioning? Good. All right, thanks. Well, it's a pleasure to be with you. And happy anniversary, Smith-Kettlewell. I haven't been here quite the whole 60 years, but it's been a while. And for those of you that can't see my slides, I'll try to describe them. I have 3 pictures of me here. Early in my career when I had hair on the top of my head, mid-career when I lost the hair, and later in my career where I've taken up an appearance very much like Yoda from Star Wars. So the title of my talk today is Insights from 37 years of seeing patients who can't see me. And to put this in context, I should probably say that my practice is heavily skewed towards geriatrics, and I thoroughly enjoyed a geriatric practice. 90% of my patients are over the age of 80, and that is kind of my defining point. Anybody below the age of 80, I consider a pediatric patient. So, all right. Look at that. Light to turn on. Just the flasher. Go right there. Okay. That one. Okay, good. I can point to things. Great. Thanks. All right. Great. So here's 2 of my mentors here at Smith-Kettlewell in 1986, and I'm a couple years behind them. Art Jampolsky, August Kohlenbrander, and they're both wonderful men that really helped me a lot as I was ending my learning portion of my career. And last week we had a wonderful honoring of Gus Kohlenbrander at Isler meeting, and he's only 91. I don't know if he's listening in on this, but he's got to go another 10 years to match Art, so we're expecting lots of things out of Gus for the next 10 years. Over that period of time, 1986 to 2023, I've learned a lot, specifically from my patients. And I think I'm getting a little bit of street smart, maybe, as time goes on. I always hope that I'm teaching my patients something, but I know that I've learned perhaps even more than they have. And I relish the lessons I've learned for life and the lessons I've learned about visual science from my patients. And it's been a fascinating review of what I've picked up over that period of time, 37 years. Certainly, I'm talking today about using available senses. And I liked this graphic, which I just found Googling senses, because it points out all the senses pointing towards the brain in the center. And senses don't function independent of the brain. Too many patients, feel they see with their eyes, touch with their hands, hear with their ears. No, it's all a brain function. And that's an important part of educating my patients about the adaptations that they have to make as a person with only partial sight. So in my opinion, the key to a patient's adaptation is they're paying attention to what they can see and not what they can no longer see. So here I have the classic picture of a glass that can be viewed as half full or half empty. And that has tremendous parallels to vision and to the visually impaired. How do they view their vision, half full or half empty? You can ask yourself that. What kind of person are you? Are you a half full person? Or are you a half empty person? I know a lot of optimists and pessimists in my life that I've met with exactly the same situations, and how they view their life can take on very different flavor and enjoyment depending on what they choose to focus on. I like this little slide. Here we have a glass, and the label on it is technically the glass is always full. Half full of water, half full of air. This is a quote of Albert Einstein's that I really find applicable to many different areas of of medical practice that I've been in. We have a fish swimming here in the water, and the caption is, "The fish will be the last to discover water." And you can visualize a nice little motorboat up on the top of the water is very aware of the water. Maybe somebody at the shore throwing stones in it, he's very aware of the water, or a swimmer that's diving into it. But the fish who's been born and lives there is really not too aware of the water. So I thought Albert had an interesting thought there, that the fish will be the last to discover water. And certainly that has, again, a lot of parallels to those with partial sight. Okay, here we have a picture of what we might call rose-colored glasses, an optometrist's view of what they're looking at. And our perceptions do become our reality. And to illustrate this, I'm going to show you a picture of a toad. So this is a not too glamorous toad, maybe a little ugly looking. And that's because I've told you it's a toad. It looks like a toad if you have the ability to see it. But if I now show you a picture of a noble horse, and I pre-warn you that it's a horse before I show you the picture, it's not hard to see the horse. But these two pictures, the toad and the horse, are the same picture. If you look at it sideways, it's not too hard to see that the nostrils of the horse are the eyes of the toad, and the eyes of the horse are the gap between the legs of hind legs of the toad. So again, how do we choose to look at our lives? How do we choose to look at our vision? So my next picture here is another classic optical illusion, where I title it "Being Chased by the Monster of Progressive Vision Loss." So you have somebody in the front foreground running away from this awful monster in the background, the vision loss. And with the bricks that are imaged there, there's a perspective that makes the rear monster look sizably bigger. But if you put them, with side by side without the bricks on it, they're the same size. And perhaps this monster of vision loss isn't as large as it seemed at first, would be my caption for that. So again, perceptions become reality, and the perception is, I have no useful vision or I have useful vision, is, I think, a really important distinction. In medicine, we have to be very aware of labels and the dangers that labels can cause, and how, with the credibility that we have as physicians, that we can change people's perception of their disease very significantly with just subtle differences. Bernie Siegel made the note that cancer doctors are often asked, how long do I have to live? And they will give them the statistical mean of what life expectancy is for a certain cell type of cancer. People then go home, put a circle around their calendar, and they die on schedule. And it becomes an aberration, because there should be a nice big range. But if you've been told you're going to die, then they die very close to when they're supposed to die. So likewise, with the term legal blindness, you have to be very careful when you're telling a person that they qualify for legal blindness. Gus Kohlenbrander, I think he's quoting Yehuda, has been noted many times to say, more people are blinded by definition than by any other cause. And it seems to me rather ludicrous that we have this dichotomy of sight, that at 20/190, you're legally normal, and at 20/210, you're legally blind. Very little difference on that dividing line between 2200. So I often have people coming to me referred by referring doctors who've been told they're legally blind, and they basically say, what's the point? I don't have useful vision. And so everything I have to do has to be geared around changing that perception into they have useful vision. So one of the tricks that I learned from Gus Kohlenbrander is measuring visual acuity at 1 meter instead of 20 feet or 6 meters down the end of the room. So there's Gus doing his test on his sister in that image. And here's me as a younger person with hair on the top of my head, testing a patient at 1 meter. And there's many advantages to that 1 meter test. At 1 meter testing distance, you can extend the range is from, instead of 2,200 on most standard charts, down to 21,000, 1 over 50 or 6 over 300, whichever unit you're going to use for measurement. I'm from Canada and I can think in metric. I think I'm happy red, white, and blue American right now, but it's kind of dumb that we have switched over to the metric system in this country. If I'm not mistaken, we have the company of Liberia and Burma. I think those are the 3 countries in the world that right now aren't metric. Divide by 5,280 or 12 or 36. That's so I like moving decimal places. So if I want to improve America, I should start a campaign. We really should become metric. Seems rather hard. Anyway, sorry, I got a bit off track there. 1 meter is 1 diopter from infinity. So when I'm doing a refraction on a person, I have to add 1 to the dioptric units to get a measurement. That's a nice thing about a 1 meter testing distance. It's also the denominator of your acuity, 1 over whatever the M unit size is the minimum diopters of add necessary to read newsprint. So that's handy. But most importantly, when I measure at 1 meter, it's of tremendous psychological benefit. So in that picture I had on the previous slide, I've often had patients tell me when I measure their acuity at 1 meter, Dr. Fletcher, you're amazing. I've never seen so good. It's been years since I could see this well. Well, of course, it's the same visual angle. It's still 2,200, but just I can get much further down the chart at a 1 meter chart than I can. And so that's the psychology of what I'm doing. So I work from success to success to success, trying to convince them that that label that they've taken on of being legally blind and not having useful vision is incorrect, and that they can use their vision. So the therapists I work with are big on the C word. So you know what the C word is in occupational therapy? Confidence. We're teaching people confidence in their activities of daily living. And it's been true since the year 1604 when William Shakespeare said in Measure for Measure, our doubts are traitors and make us lose the good we oft might win by fearing to attempt. And so 1604, that was a profound thought as it is in 2023, some 400 and some years later. It's an important concept with life. And what we're doing in low vision rehabilitation is trying to help people be confident that they can do things safely and independently and meaningfully. The key is practice. Practice makes perfect. Whether you're learning to play the piano, whether you're learning to bowl, whether you're learning to do eye surgery, whether you're learning to read, or whether you're learning to read with a visual impairment. Practice makes perfect. Here's a nice little example. I have a picture of a retina here with a fresh macular scar, which encompasses the foveal area. The hemorrhage there tells you this is not something long past, it's a current process still going on. I have labeled where the PRL is, PRL, preferred retinal locus. So that's the oculocentric reference point. So I have imaged here where my little red dot is where the macula center, the fovea, was before the scarring occurred, but the PRL is now shifted over here. In the right eye, it's shifted nasally, which means this person has to use a left eccentric viewing position to put their image they want to aim their eye at onto the PRL. So again, they're making a left eye movement to line up their oculocentric reference point, the PRL, with what they want to see. So the therapist here had this person doing a little exercise. Oops, sorry, wrong direction. And here's a word search where they're supposed to find the words and put a circle around them. And if you look at all the words they've circled there, they haven't been a very accurate job of it. They've made a lot of mistakes overshooting to the left. So for example, when they were supposed to circle the word head here, they included the F in front of it. So fahed, girl, good clock. So the letter to the left-hand side is circled. So that's what that person did when they first did that exercise. Now, when they were asked to trace these triangles, you can see they put down their pen to the left there. There's the point of the triangle they're aiming for, but they overshot to the left. Now, after doing some tracing exercise for 2 weeks, this is how accurate they were. So it was just some motor skills that needed to be recalibrated, hooked up to the oculocentric reference point instead of the fovea. It didn't take long, and it doesn't take long to rewrite these, even in geriatric patients. I believe that there's a heck of a lot of plasticity left in the geriatric visual system. And this is evidence of it. And here is how much better they were able to write a check after 2 weeks of practice. It's a lot more legible. Now, okay, I let them use a felt pen, which is easier to see too. But you know, they are a lot better at their financial management with a little bit of practice. So again, practice makes perfect with all these visual skills that we're trying to train people to do, whether you're writing under a CCTV or whatever device you're trying to do. I love this exercise. I stole this off one of the occupational therapists. I blanked out the name, so I'm HIPAA compliant here. My name is blank, and I am learning to write and to stay on the line. I'm going to do this if it kills me, and it will. My name is blank, and I know that the only way to get better is to practice. So that was being dictated to them, and they did a job of that. So you can see the therapists get the idea here. So low vision rehabilitation, in my opinion, is a heck of a lot more than magnifiers. When I first started doing low vision in 1986, there was a real tendency for the traditional low vision clinic just to be an optical one. We gave people magnifiers. So you measured their acuity, you calculated the resolution deficit, you showed them a few magnifiers, you sold them a magnifier, and you never saw the patient again. An interesting study done at Moorfield, a great eye hospital quite a while ago, but Humphrey and Thompson looked at how many of those magnifiers were used a year later, and 77% weren't. They were put in a drawer and not utilized. So that's rather discouraging that after your efforts to try to do a low vision clinic, better than 3/4 weren't even used a year later. So we did a little bit of revision here of what we think our low vision model should be. And I like the rehab model, which is used in rehab medicine for rehabilitation of all kinds of disabilities. I believe in a multi-professional team approach with a key component of that team being the patient. There's got to be patient involvement. You develop an understanding of residual visual capacity in the patient, and then you develop compensatory abilities by the drill for skill technique. You do things repetitively until they get good at it. Muscle memory, 5 minutes? All right, we'll keep moving here. So in that outcome, if you look here at how many were using the magnifier a year later, 75% were using it regularly, and 22% some of the time, only 3% were in the failure category. And that's what it was with all different kinds of goals. A lot more successful. So in my opinion, the key to improving low vision rehabilitation in America is increasing the number of well-trained therapists available to work with eye doctors. And there's much truth to my oft-repeated assessment that my main role in low vision rehabilitation is my position of authority to sell the patient on the therapists that I work with. Okay, changing gears here a little bit here. Central scotomas matter. And certainly, this is a major area of interest to me over the course of my career. Using the scanning laser ophthalmoscope, have found that better than 80% of my patients don't have a functioning fovea, and that 20% that remain, half of them basically have a significant stone within 2 degrees of fixation. They come in all different shapes and sizes, but they are very significant on how they affect reading. In a group of patients that all had the same basic acuity, and the only differential that I'm looking at here is where the scotomas were. If they didn't have a scotoma within 2 degrees of fixation, they could read at over 200 words a minute. If they had a scotoma to the right, they were under 100 words a minute. And this is the same pathologies, same acuities, just the presence of scotomas. I'm a big fan of 2 reading tests to help evaluate us and teach patients. The MN Read, which Gordon, I salute him, developed, is a wonderful test. I love it. It's useful for many things. This is what the MN Read looks like, picture of it. It tells me a lot about fluency. By using the MN Read, I discovered ring scotomas. People that didn't read well, but still had relatively good acuity, often fell into the category, as do about 20% of my patients, day in, day out. When they're macular patients, they have ring scotomas. So this large text here, the 8M unit size text, it read slowly, they speed up as the text gets smaller because they can't fit big words into their remaining island of vision. So there's an 8M letter projected onto the retina, and you're going to see a couple of letters in it, so you can understand why they read slowly. So out of the frustrations with scotomas and the MN Read not being really great at picking up on mistakes, we developed the SK Read. SK stands for Smith-Kettlewell. Wonder where that face is. Wonderful test. What I simply did was change Gordon's continuous text into non-continuous text. And I bait people for mistakes. Like, for example, the word theme here. It's a great word if you have a right-sided scotoma, because you might misread it as them, or then, or the me, or they. All those are good possibilities with a right-sided scotoma. And there's no context, no contextual clues to clue the person as to what they should be saying. So our results show that in the MN read, looking at comparable patients, about 100 consecutive patients, about 25% of patients with significant scleromas didn't make any mistakes when they're reading because they stopped and paused and verbalized the error. And so there were a total of about 175 errors in that group of patients with the MN read, while there were over 1,000 errors in the SK read on that same test, comparing them. When you get a lot more errors, you can recognize the patterns, and then really valuably, you can go back and teach the patient where they're making mistakes. And there's this, oh, that makes sense. That's why I'm making that mistake. So you teach them, if it's left or right or whatever, if something doesn't look right, move your eye to the right so you can pick up where that might be mistaken. And that education is a tremendously valuable part of low vision rehabilitation. Okay, so we found that using California Center for Visual Field Test, 90% of patients are oblivious to a binocular scotoma. Oh, I hear something quirking, so we better call it up. In low vision rehabilitation, scotomas don't go away if you ignore them. So, why do patients with the same acuity vary widely in adaptation? Because of central field differences, yep, that's one reason, and adaptation skill differences the other. So as Ralph Waldo Emerson said, that's which we persist in doing becomes easier to do. The nature of the task has changed, but our ability to do has increased. Okay. So it's been a fun journey, but the best is yet to come. Thanks for spending some time with me.
Thank you, Don. Does anybody have questions at this point?
So my name is Preeti Verghese, and Don sends me many of my participants who have macular degeneration. And what they tell me is that Don is the first clinician that they've worked with who shows them how to use their residual vision. And I think that, many of them come to me too and express their frustrations about the things that they cannot do. But I think what Don does, and combined with something that we heard from Marcello earlier today during the lightning talks about actually teaching them where their scotoma is, might actually help them, figure out where they should position their healthy retina with respect to the task that they want to accomplish. And I'll stop there because I don't want to hog everybody's time.
I saw one of Preeti's patients yesterday who's a subject that was having a hard time finding a low vision clinic. So I said, I'll fit in my schedule. We'll spend some time together. So we spent about 3 hours together. And she said, I've seen a lot of doctors in my day, and I've never, ever seen a doctor that actually told me something that was functionally helpful. And I said, yeah, that's not surprising. That is my colleagues. So they appreciate that. And that's what your subject told me yesterday.
I just want to try and wrap something up between what Josh told us and Ioni's remark to his talk and what you just told us. I think we have to face the fact that, as you said, more than 95% of the people we see or we're concerned about do have vision of some sort. And yes, some aspects of it may not work anymore. So we can draw a conclusion upon which I think we all can probably agree. Namely, the goal we have is not the good old-fashioned healing goal of the good old-fashioned medical profession. It's education. And that, by the way, also should extend to people who are not in any way affected by vision loss, so that the dumb cliches about, give the poor blind guy $1 that should go away too, and we should start doing that in school. But the education of the patients, I think that's really the center for all of us here who care about low vision.
Well said, Manfred. Thank you.
Thank you, Manfred. Okay, Brandon, you're finishing it up here.
All right, cool. I'm just curious if has ever been any thought given to what is a cutoff point for training people to use their functional vision versus using a low blindness skill, and what that might be, especially for people who are above the age of 85.
Well, just like legal blindness, it isn't a cutoff. And it's very much a fluid range where you only determine it by trial and error. How does the person respond to doing task X or Y with vision enhancement versus vision substitution? And you teach them all the ways of approaching it. And the patient is always in the driver's seat telling you what's going to work best for them. So you tell them what's available. And, for reading, I've had amazing people that read continuous text at 21,000. And, they can do that and accomplish that. There's lots of people that switch over totally to reading their narrative material at 2,200, and they're not going to do it. So it's not a cut and dried cutoff, but you're kind of aware that you're going to be shifting at some point as the acuity gets worse or as the field gets worse and so on. So definitely it's fluid and it's very variable from patient to patient and variable within the same patient over time. So I'd like to, as far as it's possible, show them all the options available, teach them, how they might be useful, and let them decide at what point they're going to use what technique. If that answers that at all? Okay, thanks.
Great. Let's thank Don again.